Imagine you have fought your weight for years. Every diet, every strategy, every restart on Monday morning. Nothing sticks. Then your doctor prescribes a diabetes drug, and something strange starts to happen. Something nobody told you to expect. Not only does the urge to overeat begin to fade, the wine you looked forward to every single evening, you stop wanting it. Cigarettes you have smoked for 15 years, the pull just disappears. And the strangest part, it doesn't feel like willpower. It feels like the desire itself has been switched off at the source. Not suppressed, turned off. This is not one person's story. Tens of thousands of patients worldwide are reporting the same thing to their doctors. And the scientific community is scrambling, right now, to understand what is actually happening inside the brain. Because it turns out Ozempic is not simply managing blood sugar. It appears to be doing something far deeper, inside the exact part of your brain that decides what you want, what you crave, and what you reach for without thinking. So, what exactly is Ozempic? Before we get to the brain, I need 90 seconds of biology. I promise it pays off immediately. When you finish a meal, your gut releases a hormone called GLP-1, glucagon-like peptide 1. Its job is entirely straightforward. Tell the pancreas to release insulin, slow digestion down, and send a signal to your brain. We have enough food. Stop eating. Now here is what matters. Your body's natural. GLP-1 vanishes from your bloodstream in about 2 minutes. It fires, does its job, and it is gone. That is the natural rhythm. Every single meal, every single time. Ozempic, Semaglutide, is a synthetic copy of that same hormone, but engineered to stay active for 168 hours. 1 injection. 7 full days of continuous signaling. That is not a subtle difference. That changes the entire picture of what happens in your body. The drug was approved for type 2 diabetes in 2017. Blood sugar stabilized. The science worked. Then the weight loss numbers arrived, and patients were losing 15, even 20% of their total body weight. The FDA approved it for obesity in 2021. It became a cultural moment almost overnight. A household name. Pharmacies ran out of stock globally. Waiting lists stretched to months. The world collectively decided this drug was about weight loss, and that was true. But it was not the whole story. Because buried inside the routine patient reports came something nobody had designed the drug to produce. Patients were not just eating less, they were wanting less of everything, and they couldn't explain why. Dopamine fires before you get the thing, not while you are enjoying it. It creates the craving, the pull. The reason your hand is already inside the chip bag 3 minutes after you clearly told yourself you were done eating for the night. Most people, including most people who talk about it on the internet, believe dopamine is the brain's pleasure chemical. You've probably heard this. It gets repeated constantly. It is wrong. Dopamine is not the pleasure chemical. Dopamine is the wanting chemical. Dopamine fires before you get the thing, not while you are enjoying it. It creates the craving, the pull. The reason your hand is already inside the chip bag 3 minutes after you clearly told yourself you were done eating for the night. Deep inside your brain sits a structure called the ventral tegmental area, the VTA. Think of it as the reward engine room. It fires dopamine down two main highways. The first reaches the nucleus accumbens, your brain's stamp that says, "Do that again." The second reaches the prefrontal cortex, your decision-making center, the rational you. When you eat that pizza, dopamine floods the nucleus accumbens. Brain files it. Good. Remember this. Repeat it. Next time you smell pizza, even hours after a full meal, the memory fires. Dopamine rises, and suddenly you want it without choosing to want it. Here is something you cannot unsee once you know it. Your dopamine response to simply looking at food can be nearly as intense as the response to actually eating it. This is not a personality flaw. This is hard biology, and it explains every food advertisement ever made. Now, what happens when this system is flooded by ultra-processed food, day after day, year after year? The spikes become so extreme and so frequent that your brain begins pulling back, actually reducing its own dopamine receptors, turning down the volume because the music is permanently too loud. And now nothing normal satisfies anymore. You need more just to feel anything at baseline. If that sounds like addiction, it should, because the mechanism is identical. So here is the moment the story completely changes. When researchers first built GLP-1 drugs, their mental map was clear and limited. Gut, pancreas, digestive system. That was the target zone. The brain wasn't part of the plan. Then they went looking for GLP-1 receptors throughout the body, and they found them sitting directly inside the ventral tegmental area, the nucleus accumbens, the prefrontal cortex, the exact three structures we just mapped as the core of the dopamine reward circuit. GLP-1 receptors, right there in the reward system. They had always been there. They were part of the original design. Scientists simply weren't looking for them in that location. Nobody had thought to ask what activating them might do. A 2024 study published in Neuroscience Applied found that semaglutide reduces food cravings while simultaneously increasing dopamine reward signaling in a more stable, balanced way. Here is the best way to picture it. Imagine your brain's reward volume knob has been cranked to maximum for years. Ozempic turns it back to 5, and here is what that recalibration means in real life. A normal meal now produces a normal reward signal. Enough. A portion feels like a portion. The almost magnetic pull toward finishing the entire pizza weakens, not because you are fighting it, but because the signal driving it is no longer amplified. 2024. Peer-reviewed. The drug doesn't remove pleasure, it restores a normal baseline. Your reward system does not disappear, it recalibrates. And a recalibrated system does not need to overcorrect anymore. A 2025 review from PMC described the specific cellular pathway. GLP-1 receptors in the VTA activate inhibitory neurons called GABA neurons, which in turn dial down dopamine activity in the reward circuit. In plain language, Ozempic is a chemical dimmer switch, and that dimmer switch lives in your brain. Not your stomach, your brain. That distinction is everything. Because if cravings are born in the brain, then the solution all along, should have been the brain. Nobody designed the alcohol finding. It arrived the way the best scientific discoveries usually do, from confused patients telling their doctors something they couldn't explain. Doctors began receiving calls that didn't fit the script. I've had 2 glasses of wine every evening for 10 years, 3 weeks in on this medication, and I haven't wanted a single glass. Should I be worried? The doctors sat up very straight at their desks. A 2024 clinical trial published in JC Wine Insight enrolled people with diagnosable alcohol use disorder, people who had genuinely struggled to cut back, many for years. Weekly alcohol consumption fell by approximately 40% compared to the placebo group. 40%. And crucially, they were not trying to drink less. Here is the detail that made the finding airtight. Researchers specifically confirmed the reduction in drinking persisted long after nausea, a common early side effect of the drug, had completely resolved. Zero statistical correlation between nausea and reduced drinking. The effect was independent, neurological. It was not only alcohol. A 2024 analysis of electronic health records from over 83,000 patients found that people prescribed GLP-1 drugs had significantly lower rates of opioid overdose, cannabis use disorder, and stimulant misuse, all compared to matched patients on different medications. And a 2024 study analyzing over 2,000 social media posts from GLP-1 users found that 23% spontaneously reported quitting or significantly reducing their smoking. Without being asked to try, they simply stopped wanting to. The mechanism is exactly what we mapped. Alcohol floods the nucleus accumbens with dopamine. That flood is the high. Ozempic turns down the volume on that flood. The reward shrinks. The craving fades. No willpower needed, just changed chemistry. I want to step outside the science for a moment. What we have just described has a human dimension that the data points alone do not capture. And I think it matters. For generations, possibly your entire life, the message about overeating has been uniform and brutal. You are simply not trying hard enough. It is laziness. It is weakness. A failure of character. Have more discipline. Make better choices. Just decide to stop. Millions of people internalized that story completely. Every relapse, every failed diet, every late-night binge they didn't plan to have. They believed the problem was moral, a deficiency not of chemistry, but of character. Here is what neuroscience now shows. The prefrontal cortex, the control room, is supposed to apply the brakes to the nucleus accumbens when it starts screaming for more. But in people living with obesity, binge eating disorder, or addiction, research demonstrates that connection is genuinely softer, biologically weaker. The brakes are lighter. That is not a moral failing. That is a measurable finding. A 2024 systematic review in physiology and behavior found that GLP-1 receptor agonists normalize what researchers call reward system dysfunction, not by willpower, not by calorie restriction, but by rebalancing the underlying neurological circuitry, that was never operating at a normal baseline in the first place. The problem was never willpower. The problem was biology. Biology that medicine is only now beginning to properly understand. And that distinction matters enormously for how we treat people, for how people treat themselves. This does not mean lifestyle is irrelevant. It does not mean these drugs are a free pass with no consequences. What it means is that the biological foundation, the reward circuitry, was always part of the equation. We simply couldn't reach it before. Now I want to be genuinely honest with you, because this is exactly where a lot of science communication fails its audience. It gives you the exciting findings and conveniently omits the uncertainty. I'm not going to do that. The science on GLP-1 drugs and the brain is real. It is peer-reviewed. It is growing steadily. But it is also young, and there are 4 specific questions that researchers have not yet answered. They are not small questions. Question 1. What happens when you stop? Most of the weight lost on GLP-1 drugs returns when patients discontinue treatment. What about the brain changes? Does the reward system recalibrate back to where it was? Does the dopamine sensitivity stay at the new level? Current research does not give us a confident answer. Question 2. Long-term effects. These drugs have only been in widespread use for a few years. What does the reward circuit look like after a decade of continuous GLP-1 receptor activation inside the brain? Could there be unexpected effects on motivation, on the capacity for pleasure in everyday life, on emotional regulation? Possibly. We are watching. Question 3. Who doesn't it work for? Significant non-responders exist, people who see little weight loss on these drugs. Are there also non-responders for the brain effects? Almost certainly yes. And the genetic factors that determine individual response are still being actively mapped. Question 4. Take this one seriously. A 2025 research review flagged a nuanced finding. GLP-1 users showed a statistically higher association with depression and suicidal thinking, while simultaneously showing a lower rate of actual suicide attempts. The authors specifically called for caution, particularly because rapid and significant weight changes can cause real psychological and physiological stress. This is why these drugs belong inside a careful, ongoing conversation with a qualified doctor, not as an isolated shortcut. The science is genuinely promising. The application requires genuine care. Both things are equally true. So here is where we land. A drug designed to manage blood sugar and slow the movement of food through your gut was quietly doing something else at the same time, retuning the part of the brain that decides what you want and how loudly it asks for it. GLP-1 receptors existed in your reward system long before any pharmaceutical company designed a drug to reach them. They were always there. They evolved to be activated by real food, in normal amounts, after normal meals. Somewhere along the way, the food environment changed faster than the brain could adapt. Clinical trials are now running specifically for alcohol use disorder, for tobacco dependence, and for opioid addiction using GLP-1 drugs. Professor Carolina Haas-Koffler at Brown University's School of Public Health described it precisely: a potential turning point in addiction psychiatry. Not a cure, a turning point. The brain doesn't want what the food industry trained it to want. It wants to feel satisfied, at a normal level, with a normal meal. That is what Ozempic is teaching us. And the lesson came from a drug designed for something else entirely. If this changed how you think about food, cravings, or what addiction actually is, share it with someone who deserves a better explanation than just try harder. And subscribe the channel to learn deep research, which will change your thoughts completely. But gradually, I will see you in the next one.